Okay, hello, Justin. It is so good to have you here. So I am Hosea, and I am today's accompanied by my friend Chelsea and Julian for today's podcast. So first thing first, Junsin, could you kindly introduce yourself to our audience and please kindly let us know your name and also your current role?
Okay. Hi. Good afternoon, everyone. I'm Jin Singh. Um, Currently, I'm a practicing pharmacist. Yeah. Thanks for having me here. Definitely. I'm a practicing pharmacist based in Singapore. Currently, working in inpatient and outpatient setting of this National Center for Infectious Diseases, NCID in short. Um, Over here, we have got inpatient setting as well as an outpatient setting in the clinical duties that we provide. Of course, this NCID is actually a purpose-built facility aimed at improving infectious disease management and prevention, largely for complex HIV and TB patients. So on top of that, we do have some dermatological patients with us as well. So there are a couple of disciplines on top of infectious diseases that we manage over here as well. So my current role, other than the clinical duties that I have, I'm also interested in pursuing some public health disciplines and other than the clinical duties, definitely I'm also concurrently holding some portfolios to coordinate pharmaceutical supplies, managing some of the outbreak responses, especially in the recent years for COVID, as well as some localized ones and some up and coming probably pathogens that we might be seeing as emerging infectious diseases of concern. On my end, we do have got some research undergoing, be it sensing studies pertaining to COVID back then, as well as probably more of antibiogram or some studies of interest that physicians have seen arise in our patient population, some pathogens that are probably more drug resistant. And as an educator, I do train pharmacy trainees, colleagues, have held public talks and have conducted some antimicrobial courses for the nurses as well. Yeah, so that's probably in brief about myself.
Thank you, Jensen. So I think your job is really, really heavy. You have a lot of workload there. If we may know, what on as a pharmacist, what are you responsible in the clinical settings, especially in the inpatient and outpatients on a daily basis?
Sure. So, in my inpatient clinical duties, we do have, but I mean, it's usually rostered and scheduled because we do not have that many like infectious diseases ward. We do cater for other general medicine cases or even surgical patients over on our end as well. But for the infectious diseases portion, definitely ward rounds is one of the main clinical duty that we are serving. And the cases we do see are rather varied. So not just the HIV or the TB patients. Since Singapore is actually a transport hub, we do have a lot of travelers coming through us. So in the recent probably month or so, we do have many travelers coming by at our facility to rule out some of these infectious diseases like the Middle East respiratory syndrome, MERS. Malaria is another one that we might have for travelers passing by or transiting through Singapore. Then, of course, it is a more seasonal thing. Throughout the year, between maybe May to October, we might see a surge in our dengue population. So those are the patient profiles that we might see in our ward rounds or the infectious diseases ward. Then, of course, we have got drug-resistant tuberculosis that we round with the physicians as well. So that will be another area that we we contribute in terms of maybe dosing, optimizing of therapy for our patients. And as clinical pharmacists, we do a spectrum of ward duties. So upon patient's admission, we will do a medication reconciliation for understanding the medication history for patients. What reviews will include definitely antimicrobial stewardship. We will do therapeutic drug monitoring if there's any drug related or involved requiring that. Actively, definitely things like re-prescribing, checking for drug interactions to reduce polypharmacy, and of course, coordinating supplies in the ward. And on the last journey, the final part of the patient's journey with us usually will be more of the discharge counselling, and that's for the inpatient setting. And for our outpatient setting, we do run drug adherence clinics for our HIV patients. So typically, we come in contact with them if they are newly started on therapy. When there's any changes to their treatment regimes, if they run into issues with adherence, so we'll try to reinforce for them, and also any drug related issues that the physicians might want us to see them for greater explanation or finding out more about their drug therapies. Yeah, so those are the main two different settings that we have over here, and I'm involved in. Yeah.
Hey, thank you, Junsin. So one thing was that is interesting to hear that you have a drug adherence clinic, especially for HIV/AIDS patients, because in Indonesia it's not really commonly known. So in the implementations of the drug adherence clinic, like usually what kind of tasks did you do and what kind of challenges that you encounter to promote adherence in HIV/AIDS patient?
Okay, maybe if I may just give a quick overview of probably the global landscape of HIV first, so that we can understand from a macro perspective, and then maybe I will share a bit of the local experience before going more into what and how we can actually contribute in terms of our capacity as pharmacists. Yeah, so in terms of HIV prevalence, or if we are talking about globally, we are looking at close to 40 million people living with HIV, and there's a incidence of about more than a million newly infected on a year-to-year basis. And this is obtained from UNAIDS fact sheet. So unfortunately, we are still seeing more than 500,000 dying from AIDS-related illnesses, opportunistic infections, and possibly not even starting on treatment. So roughly 75% are able to access antiretroviral therapy from the sensing or prevalence studies that's done globally. And so we do have a rather huge burden of or this considered an epidemic, HIV epidemic globally. And Africa remains one of the most, or rather still remains as the most severely affected, with about 3% of their population living with HIV, and they account for about two-thirds of the global prevalence. And definitely this can be multifactorial, as we understand access to healthcare is always an issue, be it from testing to treatment to some of the government policies, or maybe the health literacy aspect, or even cultural, societal factors can contribute to all these barriers for accessing treatment or even being aware of their diagnosis. So in Singapore itself, we actually are fortunate enough. We have been seeing a gradual decline of our newly infected cases over the past few years. Currently, it stands at about 5 patients in about 100,000 resident population. And in NCID, where I work at, in the outpatient setting, because we do see probably the largest HIV population in our setting. So we have about close to 50 to about 100 patients on a day-to-day basis in our clinics, run by usually about three infectious disease consultants. And usually there'll be one or two pharmacists who will be tagged to these physicians to help with any of the drug-related therapy issues that the patients might run into, or even the physicians might have issues with during their consultation with the patients, which they would like us to discuss further with the patient. And in our setting, we are currently practicing same day ART. So as soon as possible on diagnosis, we will start the treatment for these patients. And most commonly, they are actually a single tablet combination, which can be a 3-in-1 or a 2-in-1 tablet. So it reduces the need for multiple time dosing throughout the day, and it's definitely much more convenient in that sense. Yeah, so when we are talking about the selection of treatment, we definitely look at resistance patterns, definitely the lifestyle, social, economic status of the patient, the ability to afford, definitely if there's if we are able to reduce things like pill burden, drug interactions, dosing frequencies, and taking into account of like comorbidities of the patients and any other concerns that they might have, we will alleviate them before we dive into the regimen personalized or customized for them. So when we are talking about this whole idea of barriers to adherence, or maybe which I will be elaborating probably later also, if there is something that we are still lacking, definitely we can have greater efforts in terms of prevention, with diagnosis, as well as in terms of the treatment options that we have. So if we are looking at globally how we are trying to achieve this, there's a global effort by the UN, the United Nations, the 95-95-95 objective of reducing, or rather increasing the number of people being tested and diagnosed. So we have to achieve this target of 95% of those living with HIV to be diagnosed, and 95% of those diagnosed to be receiving suitable antiretroviral therapy. And for those who have been receiving these therapies, to have achieved 95% of them having virological suppression in terms of their routine lab testing and all. So unfortunately, we are still a bit lacking in terms of the last two, which is starting or receiving treatment, as well as achieving viral suppression, which boils down to most likely initiation of the therapy as well as adherence as key drivers of these barriers to like achieving these targets for this population. So of course, we still are presented with multiple challenges, be it things like health-seeking behaviors, definitely policies by the various government agencies, or even in terms of the healthcare structure and systems, as well as based on a community setting, likely outreach and education will be important in terms of advocating for untransmissible, undetectable equals to untransmissible, U equals to U. This is something that advocacy groups have been trying to educate as well in the community, as well as the various modes of transmission, definitely, so that hopefully over time the social stigma for HIV patients can be gradually reduced, which we have come definitely a long way. And following this will definitely be the sustenance of some of these existing efforts, and probably any further breakthroughs in terms of our therapies or treatment options, be it possibly a cure even, or vaccines for preventing HIV.
So you've mentioned about the selection of treatments in the outpatient settings, and you usually have three consultants with 1 to 2 pharmacists. So we want to know like how pharmacists can uniquely contribute to that, but let's start at one at a time. So you mentioned that in the selection of treatment, you have to consider the resistance pattern and also the ability to afford. So how do we pharmacists can uniquely contribute to those things?
Okay, so resistance patterns generally are done upon diagnosis. Usually, we have to determine whether the patient has got what we consider a wild type. Means this is wild type essentially means it doesn't have any resistance mutations. So pretty much they should be susceptible to any of the different big drug families that we can use for as possible antiretroviral treatment for them to initiate. So those are the very clean kind of cases that you will see. Then of course, if um, by by chance the partner or the transmission mode actually is with regard it is has got a more resistant strain of virus, then it precludes some of the possible options that we have, and that may limit the options that the patient is able to utilize. Be it so just now we mentioned as an ideal situation, if it's a wild type, definitely we will go with a single tablet, a 3-in-1, or even a 2-in-1 if the viral load allows for it. But if let's say we do run into some of these resistant mutations that usually comes back in about 1 to 2 months upon testing the blood test, then we might have to consider that they are not able to use some of this more convenient, or probably those that we know have got less maybe toxicities, and or if they have certain comorbidities, that definitely will also preclude them from some of the possible range of treatment options we have. So these are some of the considerations when we are looking at the resistance patterns. Then, of course, on our end, when we're counseling, definitely this is a check that we do. Sometimes, or rather, since we are starting this patients on same day antiretroviral therapy, so we usually might not have the information on hand at that point in time. So usually, what happens is that we will start patients with what we know typically will work as with something with a strong barrier to resistance. And then maybe in about 2 months time, or maybe as early as when the resistance pattern results comes back, we can actually consider de-escalate the patient to something that might be more suitable for the profile from the resistance pattern. So these are things that we have to monitor and trace as physicians or pharmacists. Then pertaining your question on cost, this is actually a very, very big topic, because for the longest time, actually, we do not have a very good economic kind of support for patients. Fortunately, actually for Singapore, we managed to have this recent, probably not that recent really, close to 4 to 5 years back, our Ministry of Health actually came out with a list of antiretroviral therapies which are classified as subsidized in our formulary. So this actually helps the patients in terms of reducing cost, their out-of-pocket payment, because historically these antiretroviral therapies are very expensive and can cost up to a few hundred per month just for this itself. I mean, we're just thinking from the management of HIV. If it's just HIV itself, it's a few hundred, and then for some of the patients with other comorbidities, it might add on to the health. I mean the economic cost burden for them as well. So in Singapore, we do have other layers of funding and subsidies that are available for patients. So all this, what we call things like medication assistance funds. We have got this considered mandatory medical costs, or rather medical savings, um, that is automatically ring fence for our medical related or healthcare costs. So specifically for antiretroviral therapy, we have this thing called MediSave, which allows claimable limits of up to 550 per month as of now, to cover for the just the drug cost itself, which usually on for majority of the patients should be sufficient, unless they are on a more complex regimen, or they are on multiple, or rather more of a salvage regimen or whatsoever, which will definitely increase the cost for them. Uh, so the eligibility criteria for this medication assistance fund, MediSave. Oh, sorry, MediSave is mandatory, so everyone actually has got that as a baseline. So things like medication assistance fund or MediFund are additional subsidies that are available for patients. Usually, they will work through our medical social workers to determine through things like means testing to assess their income levels, and also to determine in terms of their financial background, to determine the level or the percentage of subsidy that they are eligible for. And this definitely helps them in the long run. We back to our role when we are considering like different parts of the patient's socioeconomic status, be it drug toxicity, be it comorbidities, and definitely cost. This is also another an important area that um, the patients have to be agreeable, and also will have to be able to afford in the long run. But of course, this subsidies or additional funding that we have available for them will come in, uh, be it on an ad hoc basis as well. If let's say there's a sudden change for in terms of their, for example, financial, or rather their income earning ability actually got compromised for short term, they got retrenched, unemployed for a period of time, or whatnot. This will come in very handy for some of these patients, definitely. But of course, if we are talking about a typical working adult, the profile will be definitely different from someone who is still studying, someone who has retired, and all these are taken into consideration when we go through the counseling, or on initiation, especially on initiation. Now we have to highlight to them the financial costs down the road as well.
Okay, thank you, Junsen. So if I may ask, like, were there any like some incidents where you have to change their medications because they after you did the counseling and you weren't able to set on an agreement for the initially planned antiretroviral therapy, so you have to switch it to the more cheaper. Do the do you have like an incidents? Were there any incidents in the past few years that you've experienced?
Okay, so maybe I just have got an example to just tie in these 2 points that we just mentioned. So fairly recently, but the patient has actually changed out of the regimen. But for the longest time, there's this patient who is not exactly the most adherent. We do know about the patient's adherence as a baseline, as evident from the lab tests like viral load. They're not he or she is not well suppressed, and then we do note that from the genetic testing earlier, we mentioned about on initiation, or maybe when patient comes back with poor adherence, we might also initiate them on resistance testing to see whether the virus that's in the body has actually evolved over time. It's similar to, I guess, COVID. So COVID is like initially we have things like Delta, Omicron, and now Omicron, and now the various subvariants. So HIV also evolves over time, though likely at a much slower rate. But the acquisition of resistance mutations can occur, especially if the patients are taking their medicines on an intermittent basis. So this patient that I had, he or she is not adherent, and then over time we detected that there's resistance in the profiling of the test, a blood test that we did for him or her. So but the constraints that the patient had at that point in time was cost. So for a good probably half a year to 1 year, even though there wasn't very good control of the virus, and we do know that it's likely because of the resistance pattern in the background. We did not change for this patient because of cost considerations highlighted by the patient. And I think that there was a point in time where we were also engaging our fellow medical social worker on board to help the patient determine if there's any eligible subsidy or further kind of assistance we can offer. But because the patient has got quite a bit of savings, I think. So that was the difficulty in initiating some of the earlier mentioned subsidy schemes that we currently have. So, and on top of that, the patient has got is a single parent and has got some of this savings actually reserved for the kids. So I think that there was a rather difficult situation to manage, because on one hand, the patient requires that change in treatment, but was not keen due to cost consideration. And eventually, I mean, we, as much as we can provide, things like counseling or education, I think it has to be also in the patient's from the patient's point of view, to acknowledge that this is something that is not working for the patient. And I think likely the patient had some possible complications associated with HIV, which actually prompted the switch thereafter also. So I think it's definitely a concerted effort together with like be the physicians, with ourselves, as well as social workers, and also So overall, this holistic approach has to be kind of like a dynamic communication path for the patient to customize the best treatment option for the patient in that sense. Hope this example helps with explaining a bit more on the complexity of some of the cases that we see. Yeah.
It really does, because usually in the class we were only taught that in patient counseling we have to highlight the interactions, the contraindications, but we rarely talk about costs. And it is really heartbreaking to hear that the patient wasn't able to get a new drug because of the low cost. And coming back to the de-escalations after the resistance pattern, you mentioned that once the resistant patterns come out, sometimes patients can be de-escalated with a lower treatment. So can you briefly share what what kind of de-escalations do you usually do for them?
Okay, so if we are talking about a newly started patient, sometimes like mentioned, some of the blood test results don't come back immediately. So we do not have benefit of that information. So we might be covering a little bit in excess, be it a concurrent worrying for a concurrent like hepatitis B infection. So we have got things like tenofovir-based regimens or lamivudine that helps to cover for concurrent hepatitis B on top of HIV for newly started patients. Then, of course, when the results come back, we can probably drop the tenofovir-based regimen so that we can switch to something that, in the long run, has got less of the bone and kidney side effects associated with tenofovir-based regimens. So that's one way we actually de-escalate for patients. And another way is maybe in terms of side effect profile. So for a long, I guess in terms of treatment, in terms of the treatment, in terms of treatment history, we have got this NRTI, the non-reverse transcriptase inhibitors, things like efavirenz, rilpivirine for patients, as one of as a third agent on top of their NRTI backbone. So we have these agents over time. Sometimes they can develop issues with like their lipid profile, things like their cholesterol can go up, their triglycerides can go up due to the extended or long prolonged periods of use of some of these NNRTIs. And for that, we or maybe also possible other possible side effects like neuropsychiatric side effects, we can also de-escalate them in terms of be it dosing. Like for example, efavirenz, we do have it in higher strength of 600 milligram, and we can decrease them to maybe a 400 milligram dose. Or alternatively, we can switch to something which is that has less of this lipid impact and neuropsychiatric impact. This medicine, this NNRTI called rilpivirine. But gradually, we are also shifting away from the NNRTIs, unless patient has been very very stable on it, and cost wise is definitely more of more affordable in the long run. Then we might still keep them on this. So these are some of the possible like scenarios that we offhand I can think of. We de-escalate patients to based on maybe drug profile or drug toxicity profile, I would say.
Okay, thank you, Junsin. So one thing that I want to confirm, so in Indonesia, usually the first line of therapy will be the 3-on-1 with the tenofovir, lamivudine, and also I forgot one of them. But in
Efavirenz.
Singapore, in Singapore, do you always start with 3-in-1 too, or can you start with 1-on-1 or 2-in-1? I think you mentioned that you can start with tenofovir and lamivudine. So I just want to confirm that.
Mm. So we do not keep the tenofovir based 3-in-1 over here. We have it as a 2-in-1 Truvada, which is tenofovir and emtricitabine. And on top of that, there will be a third agent, like mentioned, either NNRTI like efavirenz or rilpivirine. This was one of the most popular, I would say, starting treatment option for patients newly started. Sorry, and more recently, we do see a shift in our practice to more integrase inhibitor based regimen. So we have got patients started on things like Triumeq, which is abacavir, lamivudine, and dolutegravir. Um, this happens to be one of the drugs that's subsidized in our formulary, so that's why it's one of the most commonly prescribed on initiation. The caveat is that it doesn't cover for the hepatitis B co-infection if there's already or rather if we don't know about the status. So usually these are used for patients whom we might already have got existing information, probably for their hepatitis B like background or serologies. Then of course we, like mentioned earlier, we do have patients also started on a 2-in-1 regimen, which is Dovato. It's a just out of the Triumac 3-in-1 is only two of the components, dolutegravir and lamivudine. So that two can be started, but have to be very mindful of things like their viral load status and of course the ability to adhere to the medications on the onset lah, because you're effectively putting them on two drug regimen. I mean, in the guidelines, it is possible to start even on a two drug regimen, but I think there are some considerations on top of that. So maybe a little bit more of considerations will include things like your back to the point on genetic testing. So the genotype testing or rather resistance mutation may put patient at risk of this specific resistance mutation called M184, which actually confers resistance to lamivudine. So if you think about it, a two-in-one drug like Dovato, dolutegravir and lamivudine, if one of them happens to be also resistant, effectively you're putting them on only a single drug regimen. Even though dolutegravir has got a very good barrier to resistance, but still putting them on a single drug regimen would not be sufficient in most patients. So, like so under that circumstance, we might not want to so quickly de-escalate patients on a two-in-one regimen, but rather maybe keep them on a Triumac 3-in-1 first, and then when the resistance profile and other lab tests are back, then we will consider de-escalating on that account.
Hey, thank you so much, Jinshin. You really answered my question. So I think since after that we have covered the initial treatment and moving on, I would like to ask more technicalities. So in terms of drug interactions and also comorbidities, what kind of problems do you usually encounter in HIV/AIDS patients?
Okay, so in terms of drug interactions, we have to be very careful with specifically the protease inhibitor class. So because of their CYP3A4 interactions, so essentially, I mean, when we are looking at CYP3A4, we do know of very, very common drugs that we use for other comorbidities like your statins or maybe even your antipsychotics or some of all these regimens or comorbidities that the patient might have can predispose them to increase exposure to some of these other concomitant drugs they are on. So things like statins, we usually may start them. So some of them like simvastatin, we typically avoid as much as possible. Things like atorvastatin, rosuvastatin, we do start on a slightly lower dose and try to cap it at, if I'm not mistaken, the manufacturer has got a labeling that limits atorvastatin to about 20 and rosuvastatin to 10 per day. So, which sometimes might not always be sufficient if the patients are like have got very bad lipid control. So, there's some ways around it. Of course, with close monitoring, we might still increase the dose beyond the manufacturer stated maximum dose, but with careful titration and also monitoring of side effects and things like your CK, your liver function, of course. Then comorbidities wise, definitely like mentioned earlier, we will be careful with other co-infections, things like hepatitis. Just now I mentioned hepatitis B. In fact, hepatitis C has got quite a few of the drugs used there that clashes with probably our NNRTIs, and and because of that, usually we might need to switch out even out of the HIV regimen if we were to use a specific hepatitis C drug regimen. And over here we have got previously we didn't have got that much options in terms of hepatitis C. So hepatitis C in recent years also has got very effective regimens, and but unfortunately some of this, or if depending on what's listed in your formulary, it may clash with the NNRTIs in particular, or maybe the protease inhibitors, which are more notorious for drug related interactions. Another one common maybe drug interaction for the protease inhibitors will be your steroidal inhalers. So your steroid inhalers generally will try to avoid things like beclomethasone because of the increased risk of exposure to this inhaled corticosteroids based on the drug interactions that we see in between the protease inhibitors and the inhaled corticosteroids. So we will typically switch them out of some of these inhalers. Sorry, maybe let me rephrase my earlier point. I think in terms of the inhaled corticosteroids, things like fluticasone are the ones that we generally try to avoid, and we might switch to beclomethasone for that for minimizing the risk of drug interactions for these patients. So we have to be very careful because some of quite a bit of our patients, at least in a Singapore context, are on fluticasone based inhaled corticosteroids. So we will need to be very careful with the drug interactions and some of these very common side effect drug interactions that we see in these patients.
So I would like to dig further about the interactions part. You mentioned that one of the example was these statins, and you have to closely monitor the creatine kinase and also the liver functions when such thing happens, that you have to increase the dose above the recommendation. So in doing those, do pharmacists take a lead on those, or do you closely collaborate with the physician as well?
Yeah, so drug interactions like that, we usually will highlight to the physicians upon knowing that there's a clash, or sometimes because the primary physician managing maybe their lipids or maybe their other comorbidities might not be the HIV or the ID specialist. So they might be seeing other specialist endocrine or various specialties for other problems, and they might not be aware. And under that circumstance, we usually will highlight to them, depending on the physician's threshold. Some are comfortable with keeping to the dose that the patient has been on and monitoring from there, because essentially patient has been maybe until they reach us, then we detect and highlight the drug interactions. Means patient might have already been long standing on both of these medications and without major issues. Then under that circumstance, as a baseline, they would still keep to it. Some who are a little bit more cautious will probably upon being highlighted, these drug interactions will maybe drop the dose accordingly and then monitor from there, maybe their lipid profile, whether or not it's something that will continue increasing based on their it's also a holistic approach in terms of lipid control. So if let's say it starts to increase because of the reduction in dose, then they might slowly adjust up accordingly, as long as the adverse effects are avoided.
So, and the next question will be, so if such thing happens, how do you usually communicate this issue to your patients? Like, how do you communicate the dose adjustment, and why do we do that, and what they can expect through the dose adjustment?
So those adjustments generally, at least the bulk of the patients that I encounter, do not have major issues. So as long as you are clear in terms of your communication to them, why, and in terms of what we are worried about, our concerns, generally they are receptive to some of these adjustments or changes that we have. But of course, one way of putting across will definitely be reassuring. So the reassurance that even though there's this drug interaction, doesn't mean that it will this maybe toxicity or this adverse effect profile will definitely happen to them. It's just that at this point in time, since we detected it, it's probably better to make the change now, and so that maybe be it on the systemic exposure of their concomitant drug will have will be I mean their bodies are able to metabolize better, or maybe more suitable for their current medication regimen. So other than that, those adjustments, since you're on it, we also do actively adjust for the renal function. So some of the more common ones that we do have will be tenofovir that was mentioned earlier. Um, but things like lamivudine, although in terms of recommendations might be on the higher side, like 50 mils per minute, we might need to start adjusting. But there are internal practices because of considering patients who are on fixed dose single tablet regimens. So under that circumstance, we might be a bit more careful, or rather, we are a bit more uh, we might not be so reactive in terms of like, your renal function is maybe less than 50 mils per minute, and hence we will definitely adjust you according to the recommendations. I mean, this is something that is discussed with the physician as well. Of course, as pharmacists, we definitely have to highlight this thing to the physicians, and depending on the physician and the practice of the institution. So on our end, for our institution, most physicians actually have got this understanding or consensus that things like lamivudine or emtricitabine have got generally safe, reasonably safe profile in terms of their renal profile. So we do not actively do an adjustment at the recommended dose. But we will still monitor, and of course, if it drops below a certain threshold, then we will still adjust for them. It's just that when there is considering that the patient renal profile has dropped, maybe as a temporary thing due to dehydration or whatsoever, it may not warrant actually such a drastic change in his or her regimen. So it can be like mentioned earlier, something that was supposed to be very convenient, like once a day dosing. The side effect profile is generally okay, and the patient has been taking it as such, and cost price is okay. Then we might stick to it. Hence the lower the higher threshold we have in terms of adjusting the patients based on their renal function. On the contrary, if let's say we actively change the patient out to the separate components of lower dosing suitable for their renal profile, it may consist of more tablets, possibly higher cost as well, because some of these are not subsidized under our formulary. So some of these considerations do come in alongside with the risk benefit we do for patients.